You can hurt somebody with a needle. These needles are tiny. Even though this is only 0.30 millimeters in diameter, you can hurt somebody with it. You know the risk of pneumothorax when you're needling around a lung field. That's harped on in lots of dry needling courses. But what about when you're needling in the paravertebral region and you're needling spinal muscles, paravertebral muscles? If you've been to one of my courses, and you probably know the risks because I make you recite them to me during a checkoff. You don't want to make your patient SAD. SAD meaning spinal cord injury, arterial injury, dural puncture, or a dorsal nerve root injury, which could all happen if you were to misplace your needle in the paravertebral region and go too deep and cause any of those injuries. We've seen a documented case in the literature by Lee and colleagues in 2011 of a spinal arterial injury in the cervical region from a 50 millimeter needle, which is the same size as this needle, being misplaced in the paravertebral muscles and going too deep and going into the spinal canal and hitting a spinal arterial artery. That resulted in a cervical epidural hematoma, which required some emergency surgery to prevent paralysis. This was a massive surgery. It was a decompressive laminectomy from C3 all the way down to T1 and a posterior cervical fusion from C3 all the way down to T1, all because of one misplaced needle. This is a phenomenal article published in the International Journal of Sports Physical Therapy. It was volume 18, issue 6, and it was published in 2023. It's written by Dr. Christy Williams, Dr. Ryan McConnell, and Dr. Stacy Lindsley at Belmont University Physical Therapy Department in collaboration with Dr. Christian Failer at the Middle Tennessee School of Anesthesia. They are examining safety considerations when dry needling the multifidi in the thoracolumbar region, and this was a cadaver study. This study was filling a gap in the literature because, just as the background in this article says, while studies have examined the safety considerations in the upper lumbar spine related to kidneys and lungs, none have investigated the possibility of entering the spinal canal in this region. And I would argue that entering the spinal canal is probably one of the most significant damaging things that could be done with a needle in this region. The purpose of the study, which was really cool by design and their methodology, is they were using cadavers, and they were doing ultrasound-guided dry needling exploration to determine if a dry needle can penetrate the ligamentum flavum at the T12L1 interspace and enter the spinal canal using a paramedian approach in a fresh, frozen, lightly fixed cadaver in the prone position. This paramedian approach is the most common dry needling technique that people use in the paravertebral region. And they were using that approach that is commonly taught in dry needling training programs to see if they could enter the spinal canal with that approach with the commonly taught technique. For the methodology, the procedure was performed at the Middle Tennessee School of Anesthesia on an 88-year-old female donor by a certified registered nurse anesthetist, a CRNA, with over 20 years of diagnostic ultrasound experience, and she also had 15 years experience performing and teaching regional anesthesia. The cadaver was placed in the prone position, and the researchers used a Sonosite Edge 2 ultrasound system to identify the interspace between T12 and L1. After identifying the T12L1 interspace, the needle was inserted and directed medially at a 22-degree angle. The needle was advanced under ultrasound guidance to determine if it could penetrate the ligamentum flavum and enter the spinal canal. For the results, the researchers demonstrated that a 0.30 by 50 millimeter dry needle inserted approximately 1 centimeter lateral to the spinous process of T12 and directed medially at a 22-degree angle could pass between adjacent vertebral lamina and penetrate the ligamentum flavum and also enter the spinal canal. As you can see in figure 3 of the ultrasound image of the spine in a parasagittal orientation, you can see the layers, the skin, and then the erector spinae muscle group. You can see the spinous processes that look like little black knots, and then you can see the intrathecal space in between those spinous processes. Most importantly, you can see the tip of the needle has passed through the ligamentum flavum and has entered the intrathecal space, as evidenced by this ultrasound image. Now we'll watch a live video of the ultrasound. You can see the erector spinae group, you can see the spinous processes, which again are those kind of knots sticking up, and then you can see the needle passing through the ligamentum flavum and entering the intrathecal space. You can see the arrow pointed to that needle, and then the needle was just retracted as well. Here's another video. The arrow will point to where that needle is going to penetrate the ligamentum flavum, which in turn will enter the spinal canal and puncture the dura, and it can cause all of the bad things that we don't want to happen. Again, because I think this is important, the researchers demonstrated that a 0.30 by 50 millimeter dry needle inserted approximately 1 centimeter lateral to the spinous process of T12 and directed medially at a 22-degree angle could pass between adjacent vertebral lamina and penetrate the ligamentum flavum and also enter the spinal canal.
In conclusion, this cadaveric study demonstrates that a 0.30 by 50 millimeter dry needle is able to penetrate the ligamentum flavum and enter the spinal canal at T12 and L1 using a dry needling technique described for the multifidus, and therefore, either purposeful or inadvertent deviations in needle placement in this area of the spine have the potential to cause neurologic injury.
It's something that I spend a lot of time talking about when I'm teaching dry needling in the paravertebral region, is how deep should the needle go when you're inserting it in the paravertebral region, and you're trying to needle the multifidi or go through the longissimus thoracis on the way to the multifidi in the lumbar region. The researchers compiled a chart that looked at documented dry needling techniques in the paravertebral region, and 8 out of 9 of them, when they state the insertion depth, it says 2 lamina. Only one of them says bony backdrop, which in essence is also the lamina. When you look at the needle length ranges in this chart, the smallest length or the shortest length is 40 millimeter, and the greatest length is 100 millimeter. There was a time in my life when I was taught how to perform dry needling early in my physical therapy career that I was taught to be very, very aggressive about finding that lamina. And if I took this 50 millimeter needle and I went in 1 finger width out from the edge of the spinous process, tapped it in, sent it all the way down, if I didn't hit the lamina, then I would pull that needle out and I would get a longer needle and I would go in and really try to find that lamina. I don't do that anymore. I've gotten a long way from being that aggressive about the lamina because you know the risk if you go too deep. You know the risk if you're looking for a lamina and you don't find the lamina and you go in between. And the risks are exactly what these researchers have shown. The risk is you can enter the spinal canal. They've shown with ultrasound guidance that you can puncture the ligamentum flavum, and they did it with a 50 millimeter needle. Imagine what you could do with a 75 millimeter needle or with a 100 millimeter needle. I know that cadaver may have been a little bit smaller, but regardless, you've got to consider your risk versus your reward when you're needling paravertebral muscles, especially when you're trying to get into the depths of the paravertebral muscles. Even if you do come 1 finger width out from the edge of the spinous process, or find the edge of the spinous process and come a finger width out, and then take your needle and tap it in, slight medial inclination, which is exactly how I teach dry needling. That's exactly how I teach dry needling in the paravertebral region. But this article showed that with a 50 millimeter needle, using that exact technique, you can get into somebody's spinal canal. They were able to puncture the ligamentum flavum under ultrasound guidance, which is, a little scary. Even though it's a little scary, I'm not saying that you should stop needling in the paravertebral region. I'm not saying that you should never use anything bigger than a 50 millimeter in the paravertebral region. I'm not saying you should only use a 30 millimeter in the paravertebral region, even though I do say that in some spots. Come to the course and you'll know why. But you need to be careful and you need to be respectful of the potential adverse events that can happen if you are too aggressive with your needle. You don't want to make your patient sad. Spinal cord injury, arteriolar injury, dural puncture, or a dorsal nerve root injury, or all the things that can happen if you, just like these researchers did, puncture the ligamentum flavum and get into someone's spinal canal. It's all about risk versus reward. Is the risk of you using a 60 or 100 millimeter needle in the spinal canal, is that really worth the benefit that the patient's going to receive from it? I would argue that it's probably not. I don't want to be too aggressive. I don't think the risk versus the reward is there, because I still see the good outcomes without going too deep or without trying to dig around and root with a needle and look for somebody's lamina. If I'm lined up and I hit the lamina, that's cool. Pat myself on the back. If I line up and I don't hit the lamina because I didn't go too deep, that's cool. Pat myself on the back. Again, it's just all about risk versus reward, and really taking these needles and really digging and going too deep and pulling it out and getting a longer needle. I think that's just a way that we should not practice dry needling anymore. And I think that this research article that was published by these cool researchers at Belmont and Middle Tennessee School of Anesthesia is good fodder for that argument, because they've proven that you can get into somebody's spinal canal, you can puncture their ligamentum flavum, even with a small needle. This was a great research article by the researchers in the physical therapy department at Belmont University, and in the Middle Tennessee School of Anesthesia's CRNA department, a great collaborative effort that they published in the International Journal of Sports Physical Therapy. I certainly encourage you to access it. It is open access, and you can find it just with a simple Google search with the title, and you can find it and you can read it and you can see the supplemental videos as well to have access to this phenomenal research. It really did fill a gap in the literature. Special thanks to Dr. Christy Williams at Belmont University for allowing me to make this video and discuss this really cool article with you. I hope that it helps. And I hope that you always just consider your risk versus your reward when you're performing dry needling, especially when you're performing dry needling in the paravertebral region. Going too deep can certainly cause a problem, and this research has certainly proved that it can cause a problem. Thanks, Dr. Williams.